My name is Andrew Cadell. It gives me great pleasure to introduce Dr. Jan Milojevic. He's an MD, PhD, and professor of medicine from Prague, or just outside of Prague, as I found out a little bit earlier. He's both an interventional cardiologist and an intensivist, a full professor of medicine at the first faculty of medicine at Charles University in Prague. He's the director of the cardiac ICU. He is the ECMO team coordinator, and his research interests include resuscitation, refractory cardiac arrest, reperfusion, ECMO, and MCS. He's written the ELSO chapter on ECPR and is the president of Euro-ELSO. Today, Janan will be presenting his article involving what was originally called a hyperinvasive, but now the invasive approach for ECPR in addition to standard therapy and refractory cardiac arrest. So I'm very pleased to announce Janan to present his paper.
Perfect. Thank you very much for the opportunity. So I'll be presenting the Prague out-of-hospital cardiac arrest trial, also called the effect of intra-arrest transport, extracorporeal cardiopulmonary resuscitation, and immediate invasive assessment and treatment on functional neurological outcome in refractory out-of-hospital cardiac arrest, a study by Dr. Milojevic and al. That was published in JAMA on February of 2022. As you know, out-of-hospital cardiac arrest, especially refractory out-of-hospital cardiac arrest, which is defined as the inability to achieve ROSC despite 5 minutes of ACLS, is associated with poor clinical outcome. There's limited data on the role of ECPR, which utilizes ECMO in circulatory arrest and an early invasive strategy with diagnostic and or therapeutic angiography in this patient population. So this study aims to look at whether an early invasive approach with intra-arrest transport, ECPR, and an invasive assessment and treatment, whether it improves survival with a favorable neurological outcome at 180 days in patients with witnessed refractory out-of-hospital cardiac arrest of suspected cardiac etiology. This was a single-center randomized controlled trial that was conducted in Prague, Czech Republic between March 2013 and October 2020. There were a total of 4,345 patients with out-of-hospital cardiac arrest in the Prague area, of which 256 patients met the eligibility criteria and were enrolled in the trial. 124 patients were randomized to the invasive group and 132 patients were randomized to the standard group. The inclusion criteria of the study were patients aged 18 to 65 with a witnessed out-of-hospital cardiac arrest of presumed cardiac etiology. They had to be in refractory out-of-hospital cardiac arrest, which was defined as the inability to achieve ROSC despite 5 minutes of adequate ACLS. They had to be unconscious, and there also had to be the availability of the ECMO team and an ICU bed for the patient. Exclusion criteria were patients with an unwitnessed out-of-hospital cardiac arrest or cardiac arrest of presumed non-cardiac etiology, those who were pregnant, if ROSC was achieved within 5 minutes of ACLS, if the patients were conscious, if they had any life-limiting comorbidities with severe organ dysfunction, if they had acute strokes, bleeding diatheses, known DNR status, or a pre-existing neurological impairment. Of those who were randomized to the invasive arm, they also had to meet ECLS inclusion criteria, which was either the inability to achieve ROSC or having achieved ROSC with persistent shock, an anticipated arrival to the cath lab within 60 minutes of collapse so that ECLS could be initiated, and of course the consensus of all team members on the initiation of ECLS. Those that showed signs of irreversible organ damage or death, those with bleeding diatheses, and if they had inadequate access for phantom cannulation, they were excluded from the trial. And if we were to look at patient characteristics between both groups, they were quite comparable between the invasive and the standard arm. So the median age was 59 in the invasive group and 57 in the standard group. Women represented 18% in the invasive group and 17% in the standard group. And the past medical history predominantly consisted of hypertension, diabetes, and coronary artery disease in both groups. The location of arrest was mostly in a public place. The initial rhythm was ventricular fibrillation, so 58% in the invasive group and 64% in the standard group. Bystander CPR was initiated in 99% of patients in the invasive group and 98% of patients in the standard group. And time from collapse to ACLS initiation was 10 minutes in the invasive group and 11 minutes in the standard group. The randomization process was as follows. Following bystander CPR initiation, the rapid response team was dispatched and the study center was notified by SMS. During ongoing CPR, there was communication between the study coordinator and the physician or paramedic on the field, during which the randomization process occurred and the patient was assigned to either the invasive or the standard group by a web-based randomization process. Crossover was permitted in 20 patients if deemed appropriate by the treating physician. So 11 patients went from the standard group to the invasive group, 10 of which were in refractory VFib, and 9 patients went from the invasive group to the standard group because the interventions were deemed to be futile. And now on to the actual intervention itself. So the invasive group underwent mechanical CPR with a mechanical chest compression device, such as the Lucas device. They had intra-arrest intranasal cooling with the Rhino Chill device, if available, and it was available until 2016, after which it was discontinued. They had intra-arrest transport to the cardiac center, so while CPR was ongoing. And as soon as they arrived to the cath lab, ECLS was initiated with fem-pem cannulation, after which a coronary angiogram plus minus angiography was done, angioplasty was done, sorry, and a pulmonary and aortic angiogram was also done. Following this, an antegrade perfusion cannula was inserted in the cannulated limb to an enhanced perfusion. The standard group predominantly underwent manual CPR. However, later on, mechanical CPR with the Lucas device was also permitted. They were transported to the hospital only following ROSC was achieved, and an early invasive strategy was encouraged. Both groups subsequently underwent standardized post-resuscitation care with targeted temperature management of 33 or 36 degrees, whichever was deemed appropriate for the patient. And looking at results, the primary outcome looked at survival with minimal or no neurological impairment at 180 days, which was defined as a cerebral performance category score of 1 or 2. And this was seen in 31.5% of patients in the invasive group and 22% of patients in the standard group. And there was no statistically significant difference between the groups. The secondary outcomes looked at survival with minimal or no neurological impairment at 30 days. And this was seen in 30.6% of patients in the invasive group and 18.2% of patients in the standard group. And there was a statistically significant difference here with the invasive group being superior. The other secondary outcome was cardiac recovery at 30 days, and this was defined as being hemodynamically stable without the support of either mechanical circulatory support or pharmacological support for at least 24 hours. And this was seen in 43.5% of patients in the invasive group and 34.1% of patients in the standard group, and there was no statistically significant difference between the groups. An interesting point was when looking at those who survived 180 days with a favorable neurological outcome, and when comparing them according to the duration of CPR administered, those who received CPR for more than 45 minutes actually seem to have done better in the invasive arm compared to the standard group, as 20 patients in that group had achieved the primary outcome compared to 6 in the standard group. And what is to note is that 4 out of the 6 patients in the standard group actually ended up crossing over to the invasive arm. So in conclusion, there was no statistically significant difference between an early invasive strategy and the standard of care in patients with refractory out-of-hospital cardiac arrest with regards to the survival with a favorable neurological outcome at 180 days. However, the trial may have been underpowered to show a significance. Thank you.
Thank you very much, Janan. It's tough to summarize an article like that so effectively. I'll turn it over to the study author, see if he has any comments, or I think he actually had a few slides he wanted to share. So maybe Janan can ask you to stop sharing. Dr. Bolovic, I think you may be muted.
Yeah. Hello, everybody. Thanks. It's a great pleasure and honor. Thanks for inviting me. It was absolutely perfect presentation of our study. Thank you. Thank you. I just want to point on a couple remarks. Let me share the presentation if I find it. First, Janine showed exactly one of the major points. This is this one, and as you can see here, the JAMA didn't allow us to show the difference over here. But as pointed out, actually, what the study showed that, and this is very similar to what was shown from Canada, as you know, from the other JAMA study from Brian Grunow 2020, that patients who benefit from intra-RS transport and eventual ECPR are those who are truly refractory, so need CPR more than 45 minutes. And you see this group, this is 6 versus 20, which is significant. And those 4 out of those 6 were actually crossed over, so they were treated invasively. So if compared as treated, it would be 2 versus 24, even more different. And the other important point from this picture shows that in those patients who were resuscitated for less than 30 minutes or 30 to 45, there was no difference. So we can interpret this as an opposite. So we didn't harm those patients in the invasive arm with a shorter cardiac arrest who were transported. And if you looked into the procedural characteristics, you would see that 27% of patients who were transported after randomization. And what is important to say that as per inclusion criteria, we had inclusion of at least 5 minutes of ACLS. So it was 10 minutes to go to the scene and at least 5 minutes. But in the real data, you see we randomized patients after 25 minutes of cardiac arrest. So it was 10 minutes to go, 15 minutes of ACLS, because the crews simply called later and they gave time for eventual ROSC. Still, those patients randomized to invasive, they got in 27% of cases, they reached the ROSC en route or immediately after arrival to hospital. So we basically didn't harm those patients by transporting them. Still, it's a very interesting actually topic to discuss. And what is interesting also, there is a other trial, randomized trial on refractory RS trial from Minneapolis, from Demetris. And if you compare, we had almost 10 times more patients. Otherwise, was pretty similar study, except for the fact that we enrolled all rhythms. They enrolled only shockables. And otherwise, we randomized patients on the scene. So our study is completely different to RS. So we compared 2 different treatment strategies versus comparing putting patients on ECMO versus nothing in patients with 50 minutes of refractory cardiac arrest. So our question was to ask whether it's feasible and whether it's beneficial to transport patients after basically 20 minutes of unsuccessful CPR. And as you can see, we had a 31.5% survival in the invasive group here. But if we look at the VF subgroup, so patients similar to RS trial, our survival was almost 50% versus 43, so 49 to 43, so basically similar survival, so very, very similar outcome. So what I would like to say is that we had to interpret, and we interpreted our study as a negative by intention to treat analysis. But if you look, I think there is many positive findings in the study, despite the fact that the primary outcome was negative. The first was the logistics and organization. We had a very high percentage of bystander CPR and also the dispatch directed CPR, which I think is the most important reason why we faced 2 times higher survival in the standard strategy arm than we expected, and then we actually assumed to have when we planned the study 10 years ago. We also had overall excellent survival with 27% from all the study CPC 1 to 2 in 180 days. And finally, there was a pure benefit in subgroups. So first in crossover, as already said, 45% of those who were crossed over from standard to invasive survived favorably. Second, there was a benefit in those with truly refractory arrest who resuscitated for more than 45 minutes. We had almost 50% survival in shockable rhythms. And finally, if we pooled all patients who ended with ECPR with a cardiac arrest of 61 to 62 minutes, so very long cardiac arrest, their overall favorable survival was 22%. So study is negative per intention to treat analysis, otherwise shows that if you have a good pre-hospital system and a cooperating cardiac center with a very fast launch of ECPR, you may end up with a very nice survival in both treatment strategies. Thanks again for inviting me, and I'm open to any discussion or question you would like to have.
That's fantastic. Yeah, it was very impressive how high the survival rate was in the control arm, particularly when you compare it to things like the paramedic trial. And one of the things that wasn't mentioned was Dr. Bolovic personally cannulated, I'm not sure the exact number, but greater than 80% of the patients who are in the hyperinvasive or invasive arm with ECPR. With that, I'd like to hand it over to anyone if there are any questions amongst the group. Maybe just to get started, what's the current status of ECPR in Prague? Is it open for business, so to speak? Is it highly selective? Because one of the things that you've said is that, or in prior interviews, is the most important thing, or one of the most important parts of an ECPR program is to knowing when to say no.
Yeah, it's been a little bit more specified at the moment. We trained 3 other people, so we are now 4 in the hospital. Trained, we established an ECPR on-call service, which is being held by 4 people, and the number of patients basically the same. It's about 1 patient per week, and we of course are more focused to shockable rhythms. We reject asystoles, and we are very selective with PEAs, which are not futile completely. We had 5 patients survived in this group, and 4 of them were invasive, so it was 8% survival, favorable, but we are very selective, and we are trying just to take patients with pulmonary embolisms who are being pre-hospitally thrombolized.
I think Dr. Schnell has his hand up there.
Yeah, thank you very much. Really fascinating presentation and an awful lot of work. Congratulations for what you've accomplished. I was impressed by one of your comments and the fact that 99% of patients got bystander CPR. I mean, I must admit, I do think a lot of the outcomes in some of these patients are predetermined by what happens in the first 5 or 10 minutes when they arrest at home. Can you tell us how you achieved that rate of bystander CPR? I think you alluded to dispatch, instructed CPR, etc. I wonder if you could expand on that.
Yes, that's an interesting point. Thanks. When we were reviewed in JAMA, they didn't believe us this number, so I had to prove it, and I had to actually bring some confidence to that. You should know, and been published before in the Eureka 2 trial a couple years ago, that the baseline rate of bystander CPR in Prague and other European cities is 80%. And and of course we selected patients. That's obvious, as you can see from our flow diagram, that we actually enrolled 6% of all cardiac arrests during the study period. So that is obvious and has been published in many other trials, that such an approach of ECPR for out-of-hospital cardiac arrest is suitable for around 5 to maximally 10% of patients. So that's the reason where we wanted to be sure that the arrest is witnessed. Still, if you look to these supplementary files, we had, I think, 4 patients who were at the end unwitnessed, because the information, as you know, during cardiac arrest, you never know what's true. So it happened. And the other point is the dispatch center directed CPR, which is even the most important thing, that the dispatcher is keeping the bystander on the phone and instructing them what to do, how to perform the massage before the crew comes. And this is a long story of a dispatch-assisted CPR in Prague, which is being encouraged for past at least 10 years. And we do have some data which are not yet published, but we are working on that to show how the percentage of bystander CPR has been increasing in the past 10 years.
That's fantastic. Any other questions from the group? One of the things that stood out as well was the duration of resuscitation, both in the invasive ECPR group and the duration in the control group was quite long. Like you alluded to a median of 46 minutes, and perhaps contributing to the fact that the ROS rate was so good and the results of good neurologic outcome were so good at 6 months. Has this been durable? So outside of the study period, are you prospectively tracking in a database, or have basically the control arm results are so good they kind of hurt you in the experimental arm? Do you think that that's durable moving outside of the study conditions?
Yeah, this needs a little bit of more description and some kind of context. The context is that I've been working for Prague EMS for 5 years, many years ago, so I know personally very well the system, and I'm in a very close cooperation with them. And we started to prepare for this study sometimes, I guess it was 2010. So there was a period of almost 3 years of preparation for the study. And the reason was, first, we had to train the interventions, train the organization, and train the logistics of the study and handover of patients and transporting, etc. We also had to arrange all the devices. We had to arrange and train the cannulation things. And I also waited 1.5 years for the ethical committee approval, because they didn't want to approve the study. So we had quite a long time for preparation. And during this preparation, we had a lot of patients, we had simply survivors who survived very prolonged cardiac arrest. And there was like 1 hour of CPR, sometimes more than 1 hour. And the crews and the paramedics and the doctors from EMS, they actually witnessed a very good results of this approach in very selected cases. And then what happened is that during the randomization, they were sometimes very disappointed by the fact that the patient has been randomized to standard arm, and they cannot take the patient for ECPR. So it was one of the reasons why they pushed us for crossover, and it was very difficult to resist for crossover first. Second reason that we did have some violations in that as presented. And the last, and importantly, they were really trying a lot in those standard arm patients. So there was very vigorous resuscitation, a lot of effort, and prolonged resuscitations when they were refused for the transport. So they were really trying hard to get the ROSC. And therefore, probably together with all the other interventions and basically all patients who got the ROSC and were transported to hospital were immediately admitted also to the cath lab. So they had immediate invasive evaluation as well, as pointed out in the protocol, that we encouraged the invasive approach, which basically meant that in all those without obvious other reasons of cardiac arrest, we perform coronary angio. So that's the reason why we probably had such a high survival in the standard arm. And I'm glad for that, despite the fact that we didn't show the difference. And the other thing is, if you look at the data, it's very clear that basically by the crossover, we sacrificed the methodology for saving those 5 patients, because if those 5 patients who were crossed over wouldn't survive, the difference would be statistically significant. But it's live and real life study.
Absolutely. I think Rohit has their hand up, brother.
Yeah, thanks. I'd like to echo the congratulations. This is just an incredible piece of work. So congratulations to you and your team. I have two questions. Maybe we could separate them. The first is just, did you observe anything with respect to age interaction, and how does age come into play in your current clinical practice when you're deciding about implementation? So that's the first question.
Yeah. Yeah, that's a obvious question. We had to set some limit. It's important and sometimes difficult to set a limit in those cases, as you know. And we set a limit on the 65 years of age, and the reason was that that's our limit for heart transplant. So we expected some patients being eventual heart transplant candidates. So we said, okay, we're not going to enroll patients over 65. In the real life, we actually enrolled a lot of patients over 65 years of age, how you can see in the supplementary file, because it's simply difficult to estimate the age of patient who is in cardiac arrest sometimes. So the crews estimated the age to be under 65, and after we got all data, it showed up that patients are older. So we of course performed the subgroup analysis, which is also presented in JAMA, and there is basically no difference. So even those patients who were 65 plus had a similar outcome, or very comparable outcome, profiting from the invasive approach. So what we changed since that time, that we don't reject patients up to 70 years of age for ECPR if it's obviously of cardiac etiology, but we are a little bit of slow or reluctant to prolong post-CPR care, because as you know, in those cases, usually within a couple of days, within 48 hours, you know how it goes and what is the chance. So as I might have said before, we say a lot of yes in this approach, and sometimes it's important to be able to say no and to be strict in this. So like withdrawal of life support, which was about 20% in both arms.
Fantastic. And then the other one is just a technical question, but can you speak to your choices of cannula sizes? Do those vary? Is it very standard for every patient at this point in your practice? And what about your anticoagulation practice at the time of cannulation and following that?
Sure. Concerning cannulation, we use a regular Getting cannulas or Mackay, whatever. And the technique which evolved during the years is very straightforward. I'm a kind of old-fashioned person in the cath lab, so for the first groin, I don't use ultrasound. I just do it because I did for 20 years femoral access. So that's. But if I don't succeed to get to proper vessel on one side, I take ultrasound for the other one, of course, to look with ultrasound. And then we just always put in the sheets in the vessels and do angiography to be sure that we are properly cannulated with the sheet in the vessel lumen, and then there's no dissection, there's good flow. And I also see the diameter, and based on diameter, I just choose the cannula. Then I put in the stiff or super stiff unplaster wire, and I don't dilate for the sake of time. I just cut the subcutaneous tissue and put in the cannula, which works perfectly well. And it shortens the time of cannulation for about 1.5 or 2 minutes. So our cannulation times in last patients was usually 10 minutes, not more, meaning from crossing the door of the cath lab to running ECMO. We had, during the whole study, where 99 patients were cannulated, we had 3 failures of cannulation. All other patients were cannulated successfully, but of course different times, with the median times I think around 11 minutes. And we do routinely in all patients the backflow cannula for the cannulated limb.
Right, and for that arterial cannula, are you finding that it ends up being a particular size, 15 French, 17 French, 19 French? Are you trying to prefer smaller cannulas?
No. Those patients need a lot of flow, so that's my approach, is to put a cannula for women at least 17 French, and for males at least 19 French, if possible, to get the flows over 4 liters. For males always, and for women at least 3.5. But I think patients in a SIRS and severe post-CPR status, they need a lot of flow. So you cannot be limited by the access, because after you cannulate those cannulas, you can never change them. So it's technically difficult to change the cannula. So if possible, we put in bigger cannulas.
And for heparin?
Yeah, heparin, it's different. We are of course afraid of bleeding, is prolonged CPRs. So there were quite a lot of patients. We didn't use any heparin for first 24 hours, just to wait what happens. They had a lot of chest injuries and lung injuries from CPR. Or we use just initial dose of 2,500 units, a maximum of 5,000 units, and then like 10 or 15,000 units per 24 hours. So kind of a mild to moderate heparinization. And if there was no bleeding in the first 24 hours, then we just heparinized them. And it's one thing against other, as you know. There were a lot of patients who had hemothoraces, who had a bleeding from trachea and the thing. So we have to be very, very careful. And if you put in large cannulas and you have a flow of 4.5 or 5 liters, you don't need heparinization for first 24 hours. It's very safe. You don't need to be afraid of any circuit problems.
Thank you.
Perfect.
Thank you.
That was fantastic. We're a couple minutes after 4, so unless there's any concluding thoughts, I'd really like to thank both Janan and Dr. Bilolovic for having this journal club. It was extremely informative, and congratulations again on a great article.
Thank you, and thank you for a perfect presentation from Janan, and thank you for inviting me. Thanks. Pleasure. Bye-bye. Have a nice day.